So my name is Erik Briers. I am a cancer patient, and in my case that is prostate cancer. I'm Vice Chair of EUROPA-WOMO, which is an umbrella organization of European prostate cancer patient support organizations. And EUROPA-WOMO is there to serve these national organizations. And that is also why we, in their place, will be in several of the projects that at European level are carried out. Well, so my cancer is prostate cancer, and in general, prostate cancer is what some call a cancer for old men. The average age of diagnosis is 69 years of age. But in my case, I was diagnosed with prostate cancer at age 50. So during surgery, there were complications which meant that I had both of the big side effects, incontinence and impotence. The aspect of the incontinence, it takes you, in my case, 6 months to resolve that, exercises, patience. But the other problem, so the impotence, is solved also, but that took years to solve, and it took surgery to solve that. But today, after 20 years, I'm in excellent shape and excellent health, because what I didn't have was recurrences of the cancer. And that was exactly what my surgeon said. My first option is to get rid of the cancer, to cure you from the cancer, and I hope without side effects. The motivation to come and to join in the discussions is because it's so important for the patients. It's very difficult to take the position of the patient, his preferences, and make them a little bit more objective. For that you need data. And in clinical trials, what we do is we test the best of the worst. So for instance, we will try a new kind of chemotherapy for patients that were already in 2 lines, 3 lines, and they progress. But not any patient who progresses is accepted in a clinical trial. We use inclusion-exclusion criteria, which means that we only want the best of these very bad patients, the best. And that is not the real patient that the clinician will see, and that's not the real patient who will be sitting in front of the clinician. The clinician then will have to see how is this patient with his comorbidities, his bad quality of his life, are we going to do this to him? What are we going to do? And that is what OPTIMA could bring by getting this real life evidence, data, putting them next to what we know from guidelines and from the evidence, and deduct from that all the proposals for treating the patient. And then discuss this with the patient. Does this is what you want? Can we offer you this or not? OPTIMA is going to do the aspect of information, shared decision making is not, it is still with the clinician and the patient. And OPTIMA will not necessarily change that, but OPTIMA will give the clinician more information. That's OPTIMA. Optimal treatment.